Hello and welcome to this microlearning event. Today we are going to be focusing on X-ray technique. My name is Dana Eisenreich. I'm a clinical training instructor for Accuray. Before joining Accuray, I worked as a radiation therapist on a CyberKnife for about 7 years. I now teach the CyberKnife treatment delivery class. The intended audience for this presentation is CyberKnife users who have ideally gone through a formal CyberKnife training. All are welcome, but the basic concepts and theory behind CyberKnife will not be discussed. We will start off today with some general X-ray technique guidelines as they relate to the CyberKnife system. Next, we will talk about each individual tracking modality and how to determine proper X-ray technique. Finally, we will talk about CT simulation technique. Typically, when we talk about the CyberKnife, the robot gets all the attention. It traverses around the patient. It's fascinating to watch. It directs beams with an impressive degree of precision. But equally important is having a high quality, optimized live image for the system to send accurate offsets to the robot. So today, we are going to focus on X-ray technique and give our KV imagers the attention they deserve. There are some unique considerations when thinking about setting technique for a CyberKnife treatment. So first and foremost, the algorithm or the brain behind the CyberKnife relies on high quality DRR and optimized live image to determine sub-millimeter offsets. Therefore, we need to spend some time setting appropriate X-ray technique and CT scanning parameters in order for the system to perform as designed. Secondly, default X-ray technique may not be or probably won't be sufficient in almost every case. Accuray's intention of having a default starting point is to force the user to very thoughtfully consider each individual patient and what starting point technique is best for them. Finally, this large distance between our X-ray source and our detector needs to be considered when setting technique. Because of the CyberKnife's capability of imaging during treatment, the detectors are of course fixed to this point on the ceiling to mitigate chances of being a treatment obstruction. We will talk about how we can overcome this limitation with setting X-ray technique specifically for CyberKnife treatments. Let's start with some general tech lines. We know that radiation therapists come from a variety of different backgrounds, so we'll start with a very general explanation. So the three values that the therapist will need to consider: KV, or the penetration power, MA, or the number of X-ray photons, and MS, the length of the exposure in milliseconds. Throughout this presentation, we will provide example starting points for all tracking modalities. They are just that, examples that we chose based on what we often see yield good results in the clinic. The intention of providing example starting points is to provide reasonable numbers that demonstrate adjustments based on patient size, target motion, target location. These are not numbers that you should just memorize and use in every case. Instead, patient size, target location must be considered in all cases. The user is responsible for adjusting technique beyond the example starting points. So what does this all mean? We know the textbook definition of KV, MA, and MS. How do we apply these to a real patient? When determining KV, consider the size of your patient and the area that you are about to expose. So increasing your KV if you have a dense or thick structure, but more is not always better. Increasing KV often will decrease the contrast in your image. So therefore, if you have a low density anatomy like the head, neck, it may benefit to leave KV at default or even lower it in some cases. Consider what was used in CT scan. In most cases, KV between 120 or 130 is sufficient. MA should also get proportionally larger due to patient size. When MA is increased, this results in more photons reaching the detector, which does increase our signal, but can in turn negatively impact structural density. If your image is overall too dark, the MA should be decreased. Something to also consider is when the user chooses an MA beyond 160, so going from 160 to 200, the system will automatically change to a larger focal spot, which could negatively impact image resolution. However, because MA and MS are used together to determine MAS or milliamperes second, you may not have to increase your MA in all cases. Instead, if you have a stable target like the spine, pelvis, you can take advantage of that and increase your MS or the length of the exposure. This will yield a higher quality image without losing structural density. Increasing KV, MA, or MS will inherently increase our integral dose to the patient. Imaging dose conservation should always be considered. However, it is much more important to have high quality images that yield accurate positioning results. I know as a therapist, I was a bit shocked when I was first introduced to the CyberKnife. It was many more images than I was used to taking during a single fraction. I must not have been alone in that mindset because a study was conducted to determine average effective dose for an average CyberKnife radiation treatment and compare that to other common procedures like a diagnostic CT or conventional treatment with MV or cone beam imaging. These numbers were determined by surveying a limited number of CyberKnife sites to establish the range of KV, MA, and exposure time settings. And from these ranges, the median values were used to calculate the typical effective dose per image pair. For respiratory treatments, this included building the correlation model. For example, if we were to compare an average hypofractionated lung treatment, the effective dose to the patient during a course of treatment would be about 3.56 millisieverts, which is actually less than one diagnostic CT scan based on the findings of this study. The reason I'm showing you this is to alleviate any uneasiness you may have about setting appropriate X-ray technique. We all want to do what's best for our patients. And of course, we want to conserve dose when possible. However, since our algorithm relies so heavily on having a high contrast, high quality image, it is much more important to optimize our X-ray technique and ensure the algorithm parameter will perform as designed. Let's start off with the simplest tracking modality. I say it's the most simple because the algorithm provides us with a brightness value. It makes setting skull technique fairly straightforward. You may consider decreasing your KV lower than default for a skull case. So our example starting point is 110 kV, 100 MA, 100 MS. From there, the user can use the brightness metric to refine their technique. So what is brightness and why do we use this metric to determine X-ray technique? Brightness compares the similarity in overall image intensity between our DRR and the acquired images. We want these images to be visually similar because the way the skull tracking algorithm works is it looks at the DRR and it looks at the live image and basically looks for differences between the two to determine translations and rotations. The algorithm is going to perform best if the images are visually similar. When images are similar, our brightness value is 0. So perfect would be 0. Our default is 5%. Accuray recommends this value to be below 2%. So by either typing in 2 or bringing your threshold slider bar down to 2%. This is typically very easy to achieve and should result in improved algorithm performance. The algorithm also relies on the gradient parameter for the assessment of live image quality relative to the DRR. Gradient has a much higher tolerance, which is typically very easy to achieve. Since gradient is measuring the amount of black and white in the images, when an external object is in our DRR, such as the robot or cabling, this is when the therapists typically experience a gradient error. Here we see a screenshot of the technique phase of the workflow. In order to achieve the brightness goal, the therapist should use the brightness metric And the goal is to get this value between 0.98 and 1.02. Small changes in technique can be achieved with KV. Larger changes in technique can be achieved with an MAS adjustment. Gradient is not usually above or even near threshold with a typical patient setup, as long as there isn't an obstruction in the image, of course. However, we have found that some headrests or patient orientation can attribute to a gradient near threshold. So since KV and gradient are directly proportional, if there's a situation where you wish to increase brightness but decrease gradient, you should choose to manipulate your MA or your MS instead of your KV. So KV and gradient are directly proportional, whereas MA and MS and gradient are inversely proportional. And the reason that we are spending all this time talking about technique for skull patients is the accuracy of the rotation corrections during delivery is directly dependent on having adequate technique. We need good visualization of the skull bones for the system to give us correct rotational values. To prove this, on the left, we see our patient setup here where our brightness is within that 2%. And we can see our skull is locked on and our offsets are looking very representative of what we see in our image viewer. So this is looking great. On the right side, this is the same phantom. It has not been moved in between images. The only difference is we intentionally set the X-ray technique very poor, resulting in a 12% brightness error. This may seem extreme, but to the human eye here, our live image really doesn't look that poor. But because it is not within that 2%, the system is having a hard time seeing the facial bones, and therefore it's not locking on correctly. Our offsets are very large. We can see here our skull bone is not locked on. So we have this brightness metric to enforce that the user sets technique within this desired range. So we could never inadvertently treat a patient like this. Now let's talk about setting technique for a spine target. When determining spine technique, one must always consider the size of their patient. We know we'll have to increase technique beyond default. Maybe just slightly for a C-spine or a very thin patient, probably much more drastically for an L-spine or a heavier set patient. An example of how we could increase technique for a spine would be setting 120 kV, 100 MA, and doubling our MS, so 200 MS. Since our patient lying supine is going to provide a nice static target, we can increase our time. As a reminder, these values are simply numbers that our clinical applications team have found success with in the field on real patients, but many factors are going to affect these starting points. Not only size, motion, density of the target, but technique varies site to site depending on the calibration of the system as well. Something to consider if your patient is laying prone, their spine is now subject to the respiratory motion. So we might consider 120 kV, 160 MA, and then decreasing the MS to 80. For spine tracking, the therapist is not provided a brightness value anymore. Instead, the recommended tool for evaluating image quality is this histogram underneath your live image. Let's talk about the technique tab in assessing image quality. There are three main ways we've identified where the user can evaluate X-ray technique. These guidelines apply to spine tracking and to lung tracking. So first and foremost, the recommended method is the histogram-based analysis. Ideally, we'd like to see a histogram that is relatively broad or spread out and pulled away from the left-hand side. We will get into a more thorough discussion of a histogram in the next slide. The next way to assess X-ray technique is to examine your raw image. We want to see some bony anatomy. So with a spine case, we want to see some ribs, maybe some vertebrae, in our raw image. And the third way to assess image quality is to compare your enhanced image to the DRR with the goal of them being visually similar. The enhanced image is simply the raw image with a smoothing filter applied. It's going to result in a much more visually pleasing image. This is what we are monitoring during treatment delivery. And we don't want our enhanced image to be significantly darker or lighter than our DRR, or the algorithm will have a hard time comparing the two. You'll notice that all three ways of evaluating X-ray technique are subjective, meaning the opinions of what is acceptable may be different from one therapist to the next. The histogram analysis is considered the recommended method because we're looking for specific characteristics in the histogram. So let's look at that in the next slide here. If you can imagine, this rectangle is that rectangle underneath your raw image. So we're looking at this box right here. If your histogram is sort of bunched up to the right-hand side, this indicates to us that the energy is too low and we'll need to increase our technique. Of course, we can only do so much on a real patient. Let's say a fiducial target, we might have to deal with a histogram that is kind of bunched up to the right-hand side like this. There are other tools we can use with fiducial targets, with window and leveling our image. So we'll talk about that in the next portion of the presentation. If your histogram is all the way to the left side, this means that the energy that you chose is excessive. So maybe this is a C-spine case where you increased your technique too much. This is indicating to you can back off a bit on the KV, MA, or MS. A centered histogram, or one just slightly to the right, is considered ideal. And regarding the shape of this histogram, a wide, spread out, or broad histogram indicates good contrast. Therefore, the histogram we see in front of us is considered ideal. It is centered or just slightly offset to the right. This indicates good contrast while conserving dose to the patient. It can be helpful to assess our histogram on the image history table to make sure that you're kind of going in the right direction as you manipulate your technique. And if you're still unsure, another tool you can use is to zoom in on your enhanced image to assess image quality. The goal is to have a really nice, crisp, enhanced image. So here on image B, we can see our vertebrae is nice and crisp. This is indicating to us our raw image is giving our system sufficient amount of data. On the other hand, here, image A is very noisy. There's little small black dots. This is telling us that our raw image is insufficient and it might lead to algorithm tracking failure. So you see here, my raw image is bright white. And for that reason, my enhanced image is very noisy. Many errors in the align phase of the workflow can stem back to poor technique. We know sometimes it's challenging for a real patient to achieve ideal technique. If you have a very large anatomy that you are imaging through, sometimes we are limited to what quality of image we're working with. For example, we might need to accept high false notes in order to treat the patient. If the system were inadvertently locking on to the incorrect vertebral body and providing us with incorrect offset, the system would interrupt delivery. User would be presented with algorithm errors that they would then have to troubleshoot. So suboptimal technique alone will not cause a mistreatment. However, spending extra time optimizing your technique can result in a more efficient and more precise treatment for your patient. Next, let's talk about fiducial tracking. Setting technique for fiducial targets can be difficult. They're often located in deep set soft tissue areas such as the prostate or the liver. The user should, of course, assess the size of their patient and the density of the tissue when deciding on technique. An example of a reasonable starting point for a static fiducial target. So let's say a prostate, 125 kV, 160 MA, and 200 ms. If the fiducial target is moving with respiration, such as the lung, liver, kidney, we actually want to decrease the ms in this case. So we would use a 125 kV, 200 MA, and an 80 ms. The recommended tool for assessing image quality is to simply verify that the user can see the fiducials against the background in your live image. So for fiducial tracking only, the user is provided with a window level tool in the technique phase of the workflow to help with this fiducial detection. In the example we see here, window leveling is not necessary, but this is because this is an example using a very low density phantom. In a real patient, window leveling for fiducial identification is almost always necessary. So just to reiterate, the goal for fiducial tracking is to achieve a live image where the fiducials can be clearly seen against the background. In this example of a histogram, it's really bunched up to the right-hand side, so less than ideal. However, this is sometimes the histogram that we're working with for these deep set tissues. So let's say this prostate. We'll need to adjust the window and level of this image to verify the fiducials. So we'll start by moving the sides of the bar. This is going to start changing our contrast of our image by bringing them in on the sides of our histogram. This is giving us a better image. And then taking the middle part of the slider bar to adjust the level or the brightness of your image is going to further refine your image. Finally, inverting the image may make it easier for the therapist to visually identify the fiducials. If your system is having a hard time visualizing fiducials, you may experience high uncertainty, incorrect offsets, DXAB errors, rigid body errors. Again, there are going to be some instances where you cannot further optimize the technique. You might have to supervise the system and continue to redirect the system. So for that reason, it is critical that we adjust the window level so that we can ensure it is locking on correctly. So in this example we see in front of us, our patient is really going to benefit from spending some time to window and level our image, or even inverting the image so that the therapist can verify fiducial identification. We also want to emphasize the need to set independent technique for camera A and camera B if you have an off midline target, like the liver or lung, for example. Likewise, it might be very helpful to unlock your window level tools so that you can set individual window level for each image. We can see here the histogram for camera A is much different shaped than the histogram for camera B. So we would want to unlock so that we can set individual window level. Here we see a screenshot of the therapist visually identifying the fiducials. So they're spending some time verifying that they can see the fiducials in camera B. And then going down to camera A, unlocking the image before making any changes. Unfortunately, the window level does not save, so the therapist would need to repeat this process in the align phase of the workflow. Finally, let's talk about synchrony lung tracking, so setting X-ray technique for these lung targets. Many things we've already talked about apply to lung tracking. First of all, since lung targets are always off of midline, consider setting individual technique for each camera. Second, always decrease your MS to at least 80, since lung targets are moving significantly with respiration. So in our example starting point, we have a 125 kV, 160 MA, and an 80 MS. If you're still seeing some motion on your image, you can further reduce your MS to 64 or even 50, and then in turn, increase your MA to compensate. Knowing what we've learned so far about assessing technique, let's look at image B, this top image. Based on those three tools we learned about, let's take a look and determine if this is adequate quality image. So my histogram is reasonably spread out. It's pulling away from the left-hand side. I can see some bony anatomy, so these are all great signs. However, my enhanced image is a little bit darker than my DRR. So I might choose to increase my technique slightly, maybe a 10% increase in the KV. Looking at A, or the bottom image, I have a lot more work to do. My histogram is really bunched up to the right-hand side. I can't see any bony anatomy here in my raw image. And my enhanced image is much, much darker than my DRR. A reasonable action would be to increase the KV, again, maybe 10-15%, and make a positive adjustment in MA. Treating with inadequate lung technique can cause uncertainty errors, tracking failure, DXAB errors, correlation errors. So again, as therapists, we're supervising the system. We need to window and level and ensure that we can see the tumor so that we can verify that we're locking on. If we spend some time really optimizing technique, the system will have a much better performance during treatment. Finally, let's spend some time talking about CT simulation technique. We've talked in depth about the importance of providing the algorithm with a high quality image, but equally important is providing the system with a high quality DRR for the system to compare that live image to. Accuray cannot give specific numbers for KV or MS due to the variety of CT scanners and the wide range of techniques. So instead, we recommend talking to your CT manufacturer and emphasize the need for clear, crisp bone that results in a high contrast image. The reason being is our tracking algorithm will perform best with a high contrast DRR that has nice crisp edges and clear feature-rich anatomy that provide that sharp transition between bone and soft tissue. To acquire this high contrast image, the therapist needs to select a CT protocol with low KV and much higher MAS than a diagnostic CT quality. If you're having consistent issues with tracking, it could be very likely related to your CT scanner settings. You can contact the clinical applications team here at Accuray if you continue to have trouble acquiring high contrast images. Although the bullet points on this slide are unrelated to technique, they are equally important to producing high quality DRR. The algorithm that drives the system that determines patient positioning decisions will only perform as designed if the DRR meets certain guidelines. We demand and expect sub-millimeter accuracy from the system. And for that to be possible, our DRR must meet certain criteria. So first and foremost, it's crucial to acquire a CT scan with no motion. Any motion on our CT scan is going to result in motion on our DRR. When we compare that DRR with motion to a live image, static live image, this is going to result in algorithm failure. To achieve an image with no motion, we encourage therapists to acquire the scan at the end of a normal exhalation. End exhale is chosen because most people spend the majority of their respiration in exhale. However, the scan can be acquired on the end of a normal inhale if this is much more comfortable for your patient. Secondly, following the slice thickness guidelines of less than 1.5 millimeters is crucial. Too thick of slices is going to result in a poor image and will lead to uncertainty errors and tracking errors. Lastly, be sure to include 10 to 15 cm superior and inferior to your target for lung and spine tracking, and 1 cm superior and anterior to your skull for skull tracking. Anytime you see a DRR where a section of the lung or the spine is missing, this could absolutely lead to tracking failure. On the last slide, we saw some poor examples of DRRs. Now let's look at what is considered acceptable. So here we see examples of how a high contrast skull CT scan produces a DRR with crisp edges and clear feature-rich anatomy, which is especially important in the facial bones for the system to determine pitch, roll, and yaw. We can see here how having that 1 cm gap anterior and superior to the skull provides the system with that little bit of background to help determine translations. Here we see examples of some high quality images of the spine that have been imported into the precision planning system. These high contrast images provide that sharp transition between bone and soft tissue, which the spine tracking algorithm relies on heavily to provide accurate rotations and translations. Thank you all for attending this microlearning presentation. We hope that this information benefits you and the patients that you treat. This presentation will be saved and will be available on Arrow in the event that you would like to watch it again or share with others.